Okay? A 20-year-old man comes to the emergency department complaining of palpitations that began when he woke up earlier today. The palpitations have been continuous and are still ongoing. He denies chest pain, shortness of breath, or dizziness. His blood pressure is 120 on 80 mm Hg and his pulse rate is 140 beats per minute. He has a respiratory rate of 23 breaths per minute. He is completely conscious throughout. Below is his ECG taken in the emergency department. This ECG is pathognomic for supraventricular tachycardia. What is the single most appropriate initial management? A. Amiodarone. B. Adenosine. C. Radiofrequency ablation. D. Carotid massage. And E. Metoprolol. And the answer will be carotid massage. And we will explain why we chose carotid massage. This ECG shows supraventricular tachycardia, and carotid massage should be attempted before giving IV adenosine. We must start with carotid massage or Valsalva maneuver, and if there is no any response, and we must start IV adenosine, and if there is no any answer also, we can repeat IV adenosine, and if there is no any response, we must think about cardioversion or DC shock. Okay, supraventricular tachycardia. Paroxysmal supraventricular tachycardia is manifested as an absolutely regular rhythm at a rate between 130 and 220 beats per minute. It's absolutely regular rhythm with a rate of 130 to 220 beats per minute. Okay, an acute management, if the patient is hemodynamically stable, should be done in the following sequence. First, Valsalva maneuver and carotid massage. Second, adenosine 6 mg IV rapid bolus or verapamil, but verapamil is rarely used for supraventricular tachycardia now, unless the patient is asthmatic, in which case verapamil is used instead of adenosine. If the first dose of adenosine is unsuccessful in converting the patient to a normal sinus rhythm, then we can repeat the treatment with 12 mg IV adenosine for another 2 episodes. And third is electrical cardioversion. If there is no any response with 3 dose of IV adenosine, then we must think about electrical cardioversion. In acute managing the patients, if the patient is hemodynamically unstable, we must go directly for cardioversion or DC shock. Prevention of episodes. For preventing the episodes, we must give the patient beta blockers and radiofrequency ablation. We must think about it if the patient has any underlying causes.